at the level of the canine, premolar and premolar, while the central and lateral now are completely healthy. We have already treated the first quadrant of this patient. From 1 to 6 in that case. It was done in June. So we are about 6 months of healing. No. Da giugno oggi quant'è? Sì, meno. No, 6 months, about 6 months.
Sì, 6, più o meno.
Che ora è adesso?
12:30.
All teeth were treated in the same surgical approach from 1 to 6. And you can guess which are the teeth that were treated with or without connective tissue graft. But once I pull the lip, I think it's quite clear where the connective tissue graft was applied, because you can see the ischemia coming from the increase in the soft tissue thickness below. But when I release, you don't see anything different from the area which was treated. And you see that from 2 to 6, there is no sign at all of the surgical procedure that was made, despite composite were made on the 3, 4, 5, and 6, and only colon advance on 1, 2. The incision, since it is such an aesthetic area, we want to make an oblique incision instead of trapezoidal incision. It must be parallel to the soft tissue margin of the adjacent tooth, and it should be displaced more cornal with respect to where is the positioning of the papilla, because this papilla is a triangular papilla that will rotate it mesial to cover the anatomic disepithelialized papilla and masking completely the vertical releasing incision. In order to avoid scar formation, we don't have to extend the vertical releasing incision more than, qual è il problema? More than the mucogingival line. Dal momento che vogliamo verticale di rilasciamento, mai mucosa alveolare, ma proprio soltanto quando ci sarà il cambiamento del tipo di sanguinamento. Ok, quindi la prima cosa che faccio è la incisione. Vai, sì, l'ho fatto. So we take this area as a reference point, parallel to the soft tissue margin, to the lateral. Until there is a small change of the quality of the bleeding. It does not bleed because it's not alive anymore. No more than this, okay? Now you make the oblique incision. This is not a nice papilla because we have a lot of sulcus inside it. Oblique incision. And the final oblique incision from the molar, the premolar. So this is the... Katia, tenga su molar. Apra un pochino. Così. This is the corona advanced flap for multiple gingival recession with only one vertical releasing incision mesial to the last tooth with gingival recession. Now I get into this line of incision until I isolate the tip of the papilla very triangular. I make the intracircular incision here in order to give the right thickness. And once the tip can be elevated, you see that now the tip is here, very thin. Everything is thin, is much aesthetic, like me. Maybe not so thin, but small. You have to bevel this incision along the vertical releasing incision until the whole triangular papilla is elevated, split thickness. You see that you can find also connective tissue in the tip, and this is very important to give stability to the surgical papilla. Now we are doing the same thing on the second surgical papilla, intracircular incision, identification of the tip, there is a sulcus here that you have to avoid in the terms that you have to give this incision much more thicker in order to incorporate also some connective tissue in the area where you can find this sulcus. Qui, Katia, sono qua. Dai un altro distance. I have to be very careful to give the right thickness where there is this invagination. You see that saline? You see that there is an invagination. You can see blood above it, and you should not see any blood because otherwise the risk of making a thinning of this surgical papilla is very high. So I have to, and this is another sulcus here. So once I elevate this papilla, I will be more thicker in order to give connective tissue together with epithelium. And this is a thicker papilla compared to the other one because of the presence of these two sulcus, which are invagination of the epithelium. You see this sulcus? You don't see because nobody is suction here. This is where the epithelium is getting into the connective tissue here and here, but since you leave the right thickness of connective tissue also in this area, there is no risk for losing the papilla. Papilla is elevated until you reach the probable area of the adjacent tooth. Come on. Now we have another papilla and still another sulcus in it. Okay. So we get into this line of incision, identification of the tip, tip elevation, again the sulcus here, so thicker. tissue here. Vedete dove ci sono tutti questi solchetti delle papille che sono legati al toothbrush del paziente? Bisogna stare veramente attenti a calibrare lo spessore della papilla. Ci vediamo da tanto, queste sono le cose più interessanti dei corsi, cioè sapere che quando incontri i solchi nelle papille chirurgiche devi stare molto più attento, anche se sembrava tutto regolare. Now we are in the last papilla. Tip of it, there is no tip at all. The tip is close to the tooth. Ci sei tu, Claudia? Now that the tip is conquered, I have to overcome this small sulcus also here by giving the right thickness to the papilla in this area. Now that the base is elevated, I have to reach the probable area of the molar tooth to complete papilla elevation. So 1, 2, 3, and 4. Now you can take the periosteum elevator and you can start with the full thickness elevation at the tooth with greater amount of keratinized tissue. And this is the second premolar, si inizia sempre dal dente con più tessuto keratinizzato until 2-3 millimeters of bone is elevated. Now you go to the premolar by inserting the periosteum elevator inside the sulcus. Again, full thickness flap elevation, and now the last one, the canine. Ma non me la aspiri sempre, su. E dai, continua. I'm looking for the bone crest, which is more apical at the level of the canine always. And it's very important that also this area of alveolar mucosa is elevated full thickness because it's very thin. È estremamente importante che quest'area di mucosa venga elevata a spessore totale perché è estremamente sottile fino a che non raggiungo la lining mucosa of the lip. Lining mucosa of the lip. Lining mucosa of the lip. This is called alveolar mucosa attached to the bone. This is called lining mucosa of the lip. This is called alveolar mucosa. This is called lining mucosa of the lip. Now we complete full thickness elevation at the mesial root of the molar. Now the flap has been elevated from the canine to the second molar, to the second premolar, and it's time to make it very, which means that the knife is completely horizontal, very horizontale, very horizontale, very horizontale, in order to leave as much as possible connective tissue along the vertical release incision. Now parallel to the bone. You see that the reason why you have to make the deep incision is because you cannot go with your probe parallel to the lining mucosa of the lip until you make this lining mucosa detaching from the periosteum. Il motivo per cui facciamo l'incisione a spessore parziale profondo è che non si può mettere la nostra sonda parallela alla mucosa alveolare fino a quando non abbiamo staccato la lining mucosa of the lip dal periosteum. Quindi, I keep my tip of the blade parallel to the bone in this way. I pull the lip, tiro il labbro until I see that the lining mucosa of the lip is detaching from the bone level. And this is done from the molar area until the distal surface of the canine. Now that the deep incision was made, is it possible for me to go with the probe parallel to the lining mucosa of the lip, and so it is possible to go superficial. But still here, so what I did blind in that area, I can use now the vertical release incision. Quindi dove là ho fatto la cieca, ora guardiamo la vertical release incision, qua è parallela all'osso, parallela all'osso, parallela all'osso, and you see that there is still a small amount of submucosal tissue attached to the bone. Very nice, because in this area I cannot go superficial, until I make this incision deep, and now you can go superficial. Visto? Now you can go superficial. It means that you can put your probe parallel to the lining mucosa of the lip. Mesial and distal to the this is parallel to the bone, this is parallel to the soft tissue. I take my blade parallel to the soft tissue, parallel to the soft tissue. From mesial, here there is bleeding. I have to check by transparency the movement of my blade through the very thin lining mucosa until all muscles are removed. Once you see that the knife does not cut completely, you have to change it, because there should be a very one shot when uniform cut. Quando vedete che la lama non taglia, dovete cambiarla, perché dovete fare un taglio netto, uniforme di tutte le inserzioni muscolari che sono presenti sui tessuti superficiali. Now there is no more muscles from the mesial, you see, to the distal. To be corneally advanced, and there is only the area of the molar that has to be improved. So we made full thickness elevation, split thickness at the deprecation area.
Qua?
Katia, ma perché oggi aspira da di là e non si mette qua come al solito?
Perché dà fastidio la luce proprio.
Così?
Non si vede niente.
Split thickness at the deprecation area. Full thickness at the mesial root. Again, split thickness with a deep incision, and then superficial. This make the papilla between 5 and 6 rotate and cover completely the premolar. Non può aspirare là? È andata la Leslie? At the level of the second premolar, we have a good amount of keratinized tissue, so we don't have to add any connective tissue graft, while at the level of the first premolar and canine, we need to add the connective tissue graft because of the root preeminence. Now we are treating our root mechanically. The distal half is treated with one hand of the curette, then you turn the curette and the other hand is used for the mesial half. Prima si tratta la metà distale della superficie vestibolare con una estremità della curette, poi si gira la curette e si tratta la metà mesiale. Root planing should be finished once the dentin sounds healthy, which means that the noise that the dentin create once the very sharpened curette is used is your reference to stop root planing. Fino a che la curette non suona sana, si estende la levigatura radicolare. Every single time there is a restoration, this should be the concept is to create a very smooth composite restoration, but also the finishing line should be really like the cement enamel junction with no sharp interruption. L'obiettivo è quindi quello di creare non solo una otturazione ben lucidata, ma è proprio quello di rendere il meno sovracontornata possibile, senza gradini, senza interruzioni nette, il passaggio fra la radice e la nuova giunzione smalto-cemento. This is the root planing procedure, and this is how root planing is performed to follow the scallop outline of the mucogingiva of the cement enamel junction without flattening too much. Questo è il modo con cui mi piace levigare la radice vicino alla giunzione smalto-cemento per non appiattirla. Here there is a you don't have to leave any type of step, and so you have to look at the profile, and you should see that the cement enamel junction is really very regular. And the finishing line is due with the only now you don't see any step between the profile of the composite restoration and the root. Va bene così? Audio? Sì, sì, chiudete un'altra sedia.
Vedi un'altra sedia da adesso. Ebbene sì. No, soltanto la barba, la corna.
Vai, Katia, su!
Ma la cosa lì?
Non è più brava la cornazione di Moma che fa dei compositi. Di quinte classi le fa meglio la cornazione di Moma. Sì, sì. No, no, ma Monaco non ne ha voglia che non le fa. Non ne ha voglia. After root planing, sei? Dai che stiamo aiutando la luce che manca. Adesso, eh? Due to the buccal prominence of the root of the canine, we will apply also some amelogenins. Dovuto alla prominenza della superficie radicolare del canino e per migliorare la qualità dell'attacco applicheremo le amelogenine. And this is done to improve the quality of the attachment between the soft tissue and the root. You see, what is the advantage of the oblique incision is that during the coronal advancement, the papilla rotates distal and there is an area of overlapping of the surgical above the anatomic papilla. This area of overlapping will create a long bevel in this area that will mask more the vertical releasing incision because only intramural suture can be performed with no need to be attached to the periosteum. Il caso dell'incisione triangolare è questa rotazione distale della papilla, mesiale, scusatemi, che si va a sovrapporre al letto ricevente. Le aree di sovrapposizione verranno soltanto disepitalizzate come le papille. E quindi, potendo fare suture solo intramurali, andiamo a ridurre il rischio di formazione di cicatrici lungo le incisioni verticali. Now, amelogenins. The surface must be clean but not dry. And now you see the cementoblasts are forming. You see the cementoblast? and also some fibroblasts which giving attachment to the new cementum. This is something that you can only see in Italy. Now it's time for the disepithelialization. You should leave the gel in situ for about 1 minute. Dovresti lasciare il gel circa 1 minuto in modo da depositare le proteine. E ora cominciamo con la disepitelizzazione.
Voi non vedete, devo fare così. Si vede?
So I trace a line where the two flaps is overlapping, and along this line I will make only disepithelization. So this is a line in which a very long bevel of connective tissue can be created. So that I will really reduce the possibility to create a scar, flashing, and this disepithelialization is continued at the level of the anatomic papilla, and it is completed with the microsurgical scissors. And also this area of epithelium is completed with the scissors, so you have a very long bevel of connective tissue. Now we complete the disepithelization. And so we get rid of all this sulcus. Completiamo la disepithelizzazione così finalmente ci liberiamo di tutte queste invaginazioni dell'epitelio nel connettivo e avremo delle papille più belle di quelle che erano prima. Vedete anche qui c'è questa continuazione del solco. So we are getting rid of this sulcus.
Chiudi gli occhi.
Now we complete this with the scissors. I don't want to suction or to saline anymore because there is the endogen above the surface. Non voglio sciacquare o aspirare troppo sulla radice perché comunque c'è il deposito delle amelogenine. Now we have to look at the cement enamel junction of the two teeth is in different level. You see that this is the level of the cement enamel junction of the canine, while this is the level of the cement enamel junction of the premolar. So if you place the connective tissue graft at the same level of the cement enamel junction of the canine, it's too apical. If you place the connective tissue graft at the cement enamel junction of the premolar, it's too coronal for the canine. So two different grafts has to be taken. One is very small, it's about 10, and the other is even smaller, more coronal, and it's about 9. Here, so one of these grafts is taken distal to the first molar. Apra bene bene. We follow this line, leaving some tissue. And then we measure this, and it should be, say, 9. Perpendicular. Calibration of the graft. Spostarla più in là. Calibration of the graft thickness at the level of the mesial vertical release incision at this angle. Calibriamo lo spessore dell'innesta all'angolo mesiale. Then perpendicular rotation, same thickness. Quindi perpendicolare, rotazione, stesso spessore. Di nuovo perpendicular rotation, same thickness. Again perpendicular rotation. Sente? Vento l'anestesia. Sentiva lì un pochino? Quindi mi fa fare brutta figura, insomma. Qui sente? Qui forse, vero? Never make anesthesia in the area that is going to be the graft. Apre grande, grande. Now we are at the level of the distal. Meglio? So here again, perpendicular rotation and give the graft the same thickness. Now I can maintain my blade parallel to the soft tissue until the two vertical release incision can be connected. Apre grande, grande. Here there is some bone. Nel distale del 7 c'è 6. Apre grande, grande. Now that the graft is open, you can connect the two vertical release incision. Until the graft is removed. Via! Now we take the second graft in this area that I don't like at all, because it's more mesial. It's the area very, very close to the rugae. I want to avoid the rugae as much as possible. Now parallel. Bene? È uno dei palati più thin del mondo. It's a very thin palate, really. But you always have the right amount of connective tissue because you use only the subepithelial connective tissue. Adesso se dovessi voluti prendere più idee. Which is a substitute of collagen, and since the teeth that has to be treated is also at the buccal aspect, I cannot make the suture towards the buccal aspect of the premolar. From distal to mesial. Now I take anchorage here with such a vertical in this area. Trying to avoid as much as possible the sulcus area. And then you come back here and make always the knot distal. Devo andare avanti? No, no, se vuoi mi prendo una prolunga delle mani. Imprimi ora. Now we do the same thing distal. In this case, there is no problem to turn around the tooth because it's not a tooth that is treated at the buccal aspect. Non c'è problema di andare intorno al 7 perché il 7 non è un dente trattato. Un po' più verso di me ce la fai, Claudia? Apra bene. Vedete che con questa sutura io metto il nodo lì e lì rimane. With the suture I put the knot there and there the suture remain during the time it takes for closing it with the second knot and third knot. And this is the advantage of the PGA suture. E questo è il vantaggio della sutura in PGA, that is not elastic. Okay, now second one. This is that one that is taken in the area of the molar, that is much better, obviously. It's more dense. There is no fatty and glandular tissue. But still, I want to have it very, very thin. Molari, la qualità è migliore, non c'è tessuto adiposo, ma io comunque la sottiglio perché voglio avere innesti estremamente sottili su entrambi i denti per non creare eccessi di volume, come dall'altra parte che nessuno si è accorto che erano stati fatti degli innesti. If there is area of epithelium which is not sustained by connective tissue, this should be completely eliminated. Okay, now we have the second one. This is that one I'm going to place at the level of the premolar tooth because it is the tooth in which there is more discrepancy between the restoration of the composite restoration and the profile of the root. And so I need more tissue to prevent shrinkage and to prevent collapse. Questo viene applicato sui premolari dove c'è più discrepanza fra il profilo della corona in composite, della restauro in composito e il profilo della radice, mentre sul canino la discrepanza è veramente minima, se vi ricordate le immagini del profilo. Ok, now we go to the patient for fixing. So this is the graft that has been to be placed at the level of the canine. And this is brother. You see that they are in two different levels. Site-specific graft application. Do it with a tunnel. again. Fix the knot at the level of the graft. Questo qua comincia a non essere più perfetto. Now we fix the mesial papilla. And again, the graft should be fixed. The knot should be fixed at the level of the graft. Posso poi sperare qui un attimo. I took the papilla too much corner. Because I want to do it in one shot, sometimes it's better to do it in 2 times. First the graft, and then the base of the connective tissue without getting too corner. And I'm trying to make the graft following the scallop shape of the cement enamel junction. Cerco di dare all'innesto l'aspetto festonato della giunzione smalto-cemento del canino a livello della giunzione smalto-cemento. I don't want to cover with the graft the connective tissue, the cement enamel junction. Now we are doing the same at the level of the premolar. Qui nessuno stira più. You see that in 2 different levels, they are at 2 different levels because of the 2 different levels of the cement enamel junction. Try to do it with the tunnel. The tunnel is very nice since you don't see anything, nobody see what you are doing, you know. It's called blind technique. Technique for blind. Dai.
Uno spezzino?
Adesso può andare con la fisiologica, C'è una sutura qua che, And again, fix the knot at the base of the papilla in order to make the connective tissue graft follow the flatter outline of the cement enamel junction of the premolar. Vedete che questo innesto segue l'andamento più piatto della giunzione smalto-cemento del premolare. Okay, now with the inserlock, make a picture of this and then close. Right. E quella riga di sangue lì che mi uccide il cuore sul premolare, vai con la fisiologica. Ok, basta. Ecco, bravo. Complimenti, grazie. Un po' più su, Claudio. Su. Un po' più sulla paziente, bravo, così. You see that the profile is the same now. Canine, profile of the composite, frigid, connected reaction. Now it's metto surgical papilla above anatomic papilla in the right position here. Say? We start here just to make a very easy suture. So I'm placing my flap, non lo so, ma è una sfida, capito? Above the bevel. And the knot should be placed above the flap to compress it here. Saline. Here. Now we'll make many of these intramural suture, farò una serie in modo da garantire una chiusura completa lungo l'incisione verticale di rilasciamento, tutta per prima intenzione. But all the time with the surgical papilla above the anatomic, tutte le volte con la papilla chirurgica sull'anatomica, troppo vicina al soft tissue margin of the adjacent tooth, too close to the soft tissue margin of the adjacent tooth. Again, you have to make the knot along the flap here, so to have the compression here. And this is possible with the PGA because during the time it takes for me to make the second knot, the knot stays there. If you use a monofilament, you change the position of the knot every single time you leave it. Il vantaggio del PGA è proprio quello che una volta fissato il nodo nella posizione giusta avete il tempo, perché rimane lì fermo, per chiuderlo mentre state preparando il secondo nodo. Try to the tunnel. I don't want to make any closure along the at the level of the alveolar mucosa in order not to risk any scar formation. Non voglio fare suture a livello della mucosa alveolare dei denti adiacenti per non fare cicatrici. This is done in the opposite direction, obviously, because I want to place it obliquata alla parte opposta perché voglio legarla al Allo spazio interprossimale adiacente senza entrare nel solco prima di fare la sutura coronale sospesa. Now I have to check if I have to make also some suturing. Now that the papilla is in the final position, even without the pinzetting, the most apical aspect, and it's here, I have to take the attached gingiva of the adjacent teeth and not the lining mucosa. So to minimize the risk for scar formation. And that's why it is not necessary and you should not extend your vertical release incision in alveolar mucosa. Questa è la ragione per cui non c'è necessità e non dovete estendere l'incisione verticale in mucosa alveolare. The flap must cover in excess. Since this papilla has the tendency to go distal, we have to fix to a medial firm point. Dal momento che questa papilla ha la tendenza ad andare distale, dobbiamo ancorarla a un punto fermo mesiale, che è la papilla fra il centrale e il laterale. Vai. So we use surgical anatomic papilla. Below the contact point. Di nuovo ancoraggio alla papilla senza che sia mai stata sollevata. Quindi è un ancoraggio mesiale under the contact point. So it's mesial anchorage because the papilla has the tendency to the closure. I have to check for the compression in the middle. Grazie, adesso che l'ho finito. Facciamo ancora così. So it should be really in the middle, and this is much difficult than when you have a trapezoidal type of papilla. That's why I always suggest you to make trapezoidal type of papilla at the first, because it's much easier to place it in the right position. Tutte le papille sono in posizione, quindi andiamo da 6. Ci sei? Pronto? Surgical. I take it more distal. Surgical, anatomic. I cannot find it. So the contact point between 4 and 5. Remember that the 5 is treated only with the coronary advanced flap, so you have to achieve a perfect adaptation of the keratinized tissue toward the convexity of the composite restoration. Il 5 è trattato solo devo evitare le zone dei solchi, have to avoid the area of the sulcus in the area of the papilla because it's a weakened area. Weaken. Now I have to check for the compression of the suture in the middle, not in the area of the sulcus. You see that the papilla in the middle, and you always have to use saline in order to see that there is no space between the surgical and anatomic papilla during the compression in this phase. Now I look for ischemia of the keratinized tissue around the convexity of the clinical crown. Now the sutures stay there because this is a repigio. Chiude? Vedete l'ischemia del tessuto keratinizzato sul 5, quando vado a chiudermi il nodo, rimane lì perché è PGA, usate il monofilamento. Try to do with the tunnel. Now this is the area of the sulcus, surgical, anatomic papilla. I take anchorage again around the papilla between 4 and 5, where I voluntarily avoid to place the knot. Prendo ancoraggio qua dove, tra 4 e 5, dove volontariamente non ho messo il nodo prima, in modo da lasciare solo un nodo per papilla. So again, surgical, anatomic papilla at the level of the foot. So we have to again achieve a very close contact between the keratinized tissue and the convexity of the composite restoration, both at the level of the 4 and at the level of the 3. I pull it, I look for ischemia in this area, and then I close it, try to make again a compression in the middle. And a good adaptation of the keratinized tissue to the convexity of the clinical crown of the canine and of the first. Now all teeth have been adapted in more coronal position with a very tight adaptation of the keratinized tissue towards the convexity of the clinical crown. While there is some area here that I would like to improve the adaptation here. So I use here a very, very thin 10 millimeter suture that make a site-specific adaptation of this area. Stai lì, col profilo. In this area. Since this has to be done in the mesial direction, I will take anchorage to the papilla between the lateral and the canine. Anche quando ho fatto prima, no? Here there is no contact point. So now you see that when I'm going to close, you should see a better adaptation of this area, which is a bit, you can see I create a compression here. Porca puttanas. This is the problem of this suture material, that is not really, it is really a bit too thin to achieve the sling suture, but it's very useful to improve adaptation. Vedete che mi si è rotta quando ho tirato perché non è una sutura idonea a fare la sling, perché si tende a rompere la sutura, e questo è un grande vantaggio, perché se si rompe la sutura vuol dire che non si rompe la papilla. Non è possibile. At the premolar, canine, and second premolar is really very nice, despite the more prominent composite restoration of the 4 and 5 with respect to the 3.